everybody. I hope you got some rest. It's gonna be a lot of electrical stuff today. EKG's conduction system, not only for me, but the morning will be the small group sessions, and in the afternoon we fixed the electrical stuff here, right? So we are all set. Um, so it's the first slides. I think yesterday when I was reading your cardiograms, and about the cardiomyopathy and different types and ischemic versus non-ischemic. So I will show you just one patient that I read echocardiogram yesterday, um, and I'd like you to participate. So it's moving. So this is the heart. That is this is the echocardiogram with contrast, um, and this is the image of the left ventricle. So sometimes if we don't have good images without the contrast, we use this, this white stuff, which is, bubbles that reflect the ultrasound waves, and we can see much better delineation of the endocardium. So do you see anything? This is just a little practical thing. Do you see anything abnormal when the heart is squeezing? Yes, no. You don't have to see it. It's it's not. So this is the left ventricle. This is the left ventricle. You don't see the atria; they are down here. The probe is here. So we are talking about the left ventricle. Just this is one of the views of the left ventricle, two-dimensional view. So you see the heart is squeezing here, the walls here. But what about here, which is the apex? You see that there is no squeezing, right? Do you see it? This part of the heart, that which is the apex, you don't see any movement. Normally it should go, all the walls should go in the systole, but you don't see any movement here. And I'll show you another view. This is different view, and again, you see the walls here are squeezing in the systole, but the apex, which is this part, does not move. So what do you think is the problem? I know I should have showed you normal function of the heart, but next time or tomorrow maybe we'll have some physiology. So is it the electrical system problem or mechanical? But you are not completely wrong. It's not a conduction system, but sometimes you can see. So there are some wall motion abnormalities on this echocardiogram. So patients who have conduction problem, I know we talk about conduction, but this is from yesterday when we talked about the ischemic cardiomyopathy. This is a mechanical problem. There is this part which is the apex does not squeeze as well because patient had myocardial infarction. And you can also see a little bit this swirling of the contrast. Do you see it here? These dark things. When we talk about the coagulation, this patient has high risk of developing blood clot in the apex because the blood swirls instead of going in and out during the systole and diastole. So this patient had myocardial infarction, and we talked about it yesterday when we talked about the late presentation of myocardial infarction, that there is a scar tissue in the whole apex, which uh, is replace the myocardium, and that's why the apex is not squeezing. So there is a scar. Mhm. Yes. So this is the view from the apex. The probe is the probe is here, and basically this is the two-dimensional view of the left ventricle. So from the apex, when we do the probe here, in this plane, this is it's a, I mean, it's technically four-chamber view, but most of what you see is the ventricle, left ventricle, and then there's a little bit part of the right ventricle. And we talked yesterday about the anatomy. The apex is mostly formed by the left ventricle, unless you have right ventricle enlargement. So again, probe is here under the breast, and it's the dimensional view focusing on the left ventricle. This is the interventricular septum. This is the anterolateral wall, and this is the apical wall. Again, swirling of the contrast, not good. Nidus for thrombus formation possibly, and this apex not squeezing well. So so let's go to the electrical. What do you think what do you find on the electrocardiogram when you see this ultrasound image, patients who had large apical or anteroapical involving the anterior wall infarct? You may see lower magnitude, yes. Do you see anything else? So these are the leads, and we'll talk about it today. V1, V2, V3, V4. These are the precordial leads that overlying the left ventricle. So the QRS complex, or this is more the Q wave. It's smaller, right? And do you see anything else? There is no transition, or there is a late transition uh, from the negative to the positive in the QRS complex, which the transition from the negative to the positive should be between lead V3 and V4. So these are all Q waves. And Q waves means, if you see pathological Q waves, that means there is a scar. So basically, you would read this EKG as a sinus rhythm with old anterior infarct, because there are already Q waves there. So this patient came late with some dyspnea that she was treated for pneumonia, and then they found these Q waves on the EKG. So they did the catheterization, and this is what they found when they did the coronary angiogram. Um, so these are coronary arteries. Um, I'll just do it one more time. This, you mean the study? So this is the cardiac catheterization, the coronary angiogram. When we put the catheter through the artery in the wrist or in the groin, and go back with the catheter, and then we inject contrast into the coronary ostia. We intubate the ostium of the left and right coronary artery, and this is the ostium of the left coronary system. So this is the left main coronary artery, and this is the left anterior descending artery. This is only one view. When we do the angiogram, we do different views, because in different views you can see better different arteries. But this is the view that is focusing on the left anterior descending artery, which is this artery that is goes on the front portion of the heart and supplies the anterior surface of the heart and the apex. So do you see anything on the angiogram here? There is a severe stenosis. There's like 90% stenosis. Uh, So the left main artery divides into the circumflex and left anterior descending artery, and then there are branches. But there is a severe stenosis in the proximal left anterior descending artery. So, so this patient underwent angioplasty. Through again, we put a little larger catheter, and uh, on the catheter there is a balloon that we inflate at the site where the stenosis is, and then we deploy the stent, which is like a little metal uh, tube that keeps the blockage open. So it's the angioplasty and stenting. This is the balloon that is inflated in the area of the stenosis. And then I think you can see, you may not be able to see it well, but you know, there is already stent here. Uh, so here, you know, this is where the blockage was, and you know there is a stent. There is still a little bit stenosis here and here, some irregularities, but the main stenosis was fixed. So he presented with a late presentation of myocardial infarction. The problem is that when she came late, um, she already developed scar tissue in the myocardium, and you know this echocardiogram is done 4 years later, and she still has basically unchanged cardiac function with the scar tissue involving the apex. So this was, you know, just little case presentation from yesterday um, about the when we talked about the ischemic cardiomyopathy. All right, so let's go. Any questions? Let's go to the interpretation of electrocardiogram. This will be a brief summary about the conduction system and reflection of the conduction system in terms of the electrical activity that we detect from the heart by doing electrocardiogram. Uh, it's the electrocardiogram is the basic test for cardiology, and even if you are non-cardiologist, you should know the basics of the electrocardiogram. So you know, or at least you should see and learn what is the main pathology when you read, you know, when you read the electrocardiograms. Yes. Yes, when we, you know, when we place the stent before we deploy the stent, you know, if we go to the detail, first, you know, we have to put a wire through that stenosis, which is like guiding wire, and then uh, on that wire we put a catheter, and on the tip of the catheter there is a stent. So we put it, and there are the markers, so we constantly inject little small amount of contrast so we can see where the blockage is, and it should be basically in the middle uh, where the stent is. So we always inject a little contrast so we can see if the blockage is in the middle, and then we deploy the stent. Sometimes there may be complications which we don't have to talk about. Sometimes we have to put two stents if there is a long stenosis. There may be a little dissection, which we have to seal with another stent. But you know, this is just injecting the contrast, seeing the stenosis. Um, so uh, the electrical conduction system of the heart consists of the uh, sinoatrial node or sinus node. That's where the normal physiological electrical impulse starts. Sinus node is located where? I know, and what it is? Left or right? Right atrium, correct. And what is this structure? That's right. You listened yesterday. So it's a superiorly at the entrance of the superior vena cava to the, you know, to the right right atrium. Um, So the electrical impulse starts in the sinus node and then spreads through the atria, left and right atrium, to concentrate back in the atrioventricular node or the AV node, which is located close to the tricuspid valve. And then the electrical impulse conducts and slows the conduction through the atrioventricular node. There is a slower conduction, and then uh, it spreads through the bundle of His, which is the next structure that is past the atrioventricular node. And then um, the electrical impulse conducts through the branches. There is a right bundle branch block and left bundle branch block, which left bundle branch block um, divides into the hemiblock or left anterior and left posterior fascicular block. Yes. Uh-huh. And what was the question on the left side? If why do we have two anterior and posterior fascicular block? I didn't understand the question. So yes, on the left side there is a thicker myocardium, and the question was what? Yeah, it's more, yes, it's more robust because the to have a synchronized cardiac action. Uh, that's why we have two bundles, on the left side, because left ventricle is larger and thicker, and so that's why we have left anterior and left posterior fascicular block. So because the heart has to squeeze and relax in synchrony. So yes, so that's why on the left side there are two branches. And then the electrical impulse spreads through the myocardium uh, by the way of Purkinje fibers. Now, we'll talk about the correlation of the electrical impulse and conduction that you will see on the rhythm strip or the electrocardiogram. Um, so what is the original, um, have you seen or have you read about the electrocardiogram? There are different waves on the electrocardiogram, right? First, positive deflection is called P wave, and then the line after the P wave is PR segment, um, which is reflecting the conduction through the atria and the AV node. So P wave and the PR segment, conduction, initial formation of the impulse in the sinus node, and then conduction of the impulse through the atria and the AV node. The next step in the conduction is spread of the electrical impulse through the ventricles by using the branches, right? The bundle of His and right and left bundle branch. And it's reflected on the electrocardiogram by the QRS complex. So the Q wave is the initial negative deflection. We talked about when the patient who had that myocardial infarction, these were pathological Q waves, which were taller and wider. This is normal physiological Q wave. And then there is a QRS complex, and then which is um, uh, caused by the depolarization in the ventricles, and the S wave, which is the second negative deflection in the QRS complex. So again, summarize: P wave caused by depolarization of the atria after electrical impulse starts in the sinus node. QRS complex is the polarization of the ventricles. And PR segment is a spread of the electrical impulse and slowing the conduction through the atrioventricular node or the AV node. P wave, that's the last. There is a ST segment after the end of QRS complex, and then the T wave, which reflects the repolarization of the ventricle. We'll talk about the physiology tomorrow, the electrical impulse and the polarization and repolarization. But the T wave reflects the depolarization of the ventricles. One more time. Atrial depolarization and delay in the AV node is reflected by the PR segment. Now this delay allows the atria, because the atria has to contract before the ventricles. So the contraction of the atrium during the normal cardiac cycles causes more blood to be pushed into the left and right ventricle before the ventricle systolic. So that this delay in the AV node allows the atria to contract first, and then the second part if the contraction of the ventricle after the ventricular depolarization. Yes, they're to what? I mean, they contract at the same time, but the atrial contraction is more robust at the end of the diastole. There is a contraction of the left atrium, but because the electrical impulse, when it starts in the sinus node, there are different electrical pathways, and so the impulse spreads evenly um, through the left and right atrium. But there is more electrical pathways on the in the left atrium. So again, the main thing is to synchronize the whole action, so the electrical impulse gets and concentrates in the AV node at the same time. Yeah, the parasympathetic and sympathetic system in terms of the uh, cardiac electrical function affects primarily the sinus node. So it affects the sinus node, and it's and we'll talk about it. It either slows the action, uh, or which is the vagus nerve, the parasympathetic system, or sympathetic system increases the action of the AV node and increases the firing from the sinus node and increases the firing of the sinus node, causing either bradycardia when there is an increased vagal tone or tachycardia, which can be physiological. So it affects primarily the sinus node. And so this is the sinoatrial node. That's because there are different pacemakers in the heart. There is a sinus node, there is an AV node, and then there is the tissue in the ventricle is also capable of pacing the heart. Patients who come with complete heart block, if they develop block along the way uh, below the atrioventricular node, um, they would, if there was no other electrical pacemaker in the heart, they would die because they were not be able to conduct the impulse through the atria to the ventricles. So this is like safety mechanism. There are different excitable tissues in the heart, three different ones which are capable of creating new electrical impulse if the sinus node doesn't work. So, but the sinus node is the dominant pacemaker. That's why the rate of the electrical impulse is faster between normal physiological rate is between 60 to 100 beats per minute. The second pacemaker is the atrioventricular node, which is the backup, the second or the first backup pacemaker, and the rate is slower. That's why the sinus node is the preferential pacemaker, and that's why where the impulse starts, because there is a faster rate in the sinus node. So the rate in the atrioventricular node is 40 to 60 beats per minute. So if there is patient who comes with the heart block, they still have two possibilities of being paced. Initially, either through the AV node, and then if the AV node doesn't work, doesn't take the function as a second pacemaker, the ventricle cells are the third backup pacemaker, and their rate is much slower. And that's why how we can also tell patients who come with complete heart block based on the heart rate and the morphology of the QRS complex. We can tell if the backup impulse starts either in the AV node or in the ventricle. So if they have a junctional, we call it heart block with junctional escape rhythm. If the heart rhythm is in the 40s or low 50s, and we can see heart block on the electrocardiogram, this is usually from the second pacemaker, which is the AV node. If the heart rate is around 30, 28, 25, obviously patients are more sicker because they don't generate the cardiac output as good as if patients who have normal heart rate. So patients who come with lower heart rate, they are sicker, they have low blood pressure, and they need emergent pacemaker implantation. Now this is the EKG paper. Have you reviewed it before or no? There are a lot of squares, right? So the EKG has squares. You should remember just the basic stuff. You know, there is a big, there are big squares here and the small squares. So this is the one big square, which the length is 0.2 seconds or 200 milliseconds. And there are, in the big square, there are 5 smaller squares. So what is the duration of the one smaller square? 0.2 what? 0.04 second, right? Or 40 milliseconds. So one small square is 40 milliseconds. One big square has 5 small squares is 200 milliseconds or 0.2 seconds. And the height is in the millivolts. One big square, the height of the complex is 0.5 millivolts. So if you have a QRS complex that has height of the one big square, the complex is 0.5 millivolts tall. So like on this example, this is the QRS complex. There is about 1.5 big squares, so 0.75 millivolts, right? It's less than 1 millivolt. Is it clear? You will need to remember these numbers when you assess the heart rates, when you assess the intervals and the duration of different complexes, PR, QRS, and QT complexes. So one big square, 0.2 seconds, which is 200 milliseconds. One small square, 0.04 seconds or 40 milliseconds. Now, this is the rhythm strip, which has a duration of 6 seconds. If we said that one square is 0.2, 1 second would be how many big squares? 5, right? So 1 second on the EKG is 5 big squares. If you see that, there is like pause, which can be as long, it can be shorter, longer. If it affects or if the pause is in the duration of 3 seconds, it would be how many big boxes? 3 second, 15, right? So 15 big boxes is 3 seconds. Every 3 seconds, 15 large boxes. So the rhythm analysis, when you read the EKGs, you should always have structure. Um, and when you have a structure, that means that you don't miss any important features or important pathology on the electrocardiogram. First step, calculate heart rate. The second step is if the heart rhythm is regular or irregular. The third step is if the rhythm is sinus or non-sinus. If you see that there are P waves in front of each QRS complex, it's generally, if the morphology of P wave is correct, um, usually is sinus rhythm. And then determine different intervals, which we start with the PR interval, then QRS and QT intervals. Duration of QRS complex, we'll talk about it. Um, and then we calculate QT interval, which is important to if the QT interval, which is interval from the end of the QRS complex to the end of the T wave. If it's prolonged, patients who have prolonged QT interval for different reasons, most commonly it's medications or it could be congenital abnormalities, they are at risk of developing malignant ventricular arrhythmias. And also antiarrhythmic medications that treat different heart rhythms can prolong, some of the antiarrhythmic medications can prolong the QT interval. So the third interval, QT interval is important in terms of assessment for proarrhythmic risk. How do we calculate the heart rate on the electrocardiogram? Oh, you have formula? There are different ways, right? Again, I usually use either, there are two formulas that we use. Um, First, you calculate the length between two QRS complexes. Maybe you mentioned, that this is the formula, and then you divide 300 divided by the number of uh, big boxes between. Is the formula that you mentioned? So this heart rate, there are about 1 to 3 boxes between the RR interval, right? So 300 divided by 3, so the heart rate is around 100. That's the most simple way, and I'll show you in the next slides. The other thing here on this rhythm strip, this is a 6 second, 3 seconds and 3 seconds. This is a 6 second strip, so you can calculate number of QRS complexes: 1, 2, 3, 4, 5, 6, 7, 8, 9, almost 10. And because it's a 6 second strip, 60 second, because heart rate is calculated beats per minute, so you multiply by 10, right? So it's around 100. Here it's 90, but it's around between 90 to 100 because there is almost another QRS complex here. Is that clear? Because it's very important to calculate the heart rate. So if you have a regular rhythm, you can calculate the duration between two RR complexes and how many big boxes, and divide 300 divided by number of boxes between two QRS complexes. On the regular electrocardiogram that you will review, I think, in the afternoon, there is a 10-second on the bottom, there is a 10-second rhythm strip. So if you have patients who come with irregular heart rate, irregular heartbeat, you calculate on that lower strip the number of QRS complexes. And because it's a 10-second strip, you multiply by 6 and you will get heart rate. And that's the most accurate assessment. That's the heart rate over minute, beats per minute. So this is what we were talking about. Um, if there are 2 boxes, the heart rate is 150, 3 boxes 100, 4 boxes 300 divided by 4, 75, and 5 boxes 300 divided by 5, its heart rate is 60. If you have 6 boxes between 2 QRS complexes, the heart rate is 50, 300 divided by 6. All right, so that's how you calculate the heart rates. Now, irregular versus irregular rhythm. Again, you should ideally should have a caliper, and you can basically put the caliper between the 2 QRS complexes and march it if the heart, if the heart rhythm is regular or irregular. There may be slight irregularity even in normal heart rhythm because of what? I said normal. Patients who have normal electrocardiogram. Why there is some irregularity in between your normal patients like you? If you're normal, uh, it's type of heart rate variability. Yes, it's called sinus or respiratory arrhythmia. The inspiration and expiration slightly changes the heart rate. So there is a little irregularity between the QRS complexes even in patients who have normal rhythm. So this is normal regular heart rhythm. See, the distance between two RR intervals is the same. And then P waves. When you see the electrocardiogram, you should always look at the P waves. Make sure they are in front of each QRS complex. It's really important because there are some missing P waves. The heart rhythm may not be sinus. So these are sinus P waves in front of each. They all look the same. So they all originate in the sinus node. This is normal sinus rhythm. And then we talked about the PR interval, which is the initial interval that we monitor. Normal PR interval is between the start of the P wave and the start of the QRS complex. 120 or 200 milliseconds or 0.12 to 0.2 seconds. So that's normal PR interval. When you have a prolonged PR interval, if it's more than 200 milliseconds or more than 0.2 seconds, how is it called? Is the initial and most benign heart block. It's called first degree atrioventricular block. So if you have prolonged PR interval more than 0.2 seconds, which is more than one big box, um, there is a delay conduction through the atria and through the AV node, and it's called first degree atrioventricular block. So remember this number 0.12 to 0.2 seconds. It's a normal PR interval. What about if it's too short? That means that the QRS complex starts a little bit earlier. It can happen in young patients, very young patients who have fast electrical conduction through the atria. When it's pathological, the most common, what is the most common condition? Who is gonna get it can go to cardiology. When the most common pathology when the PR interval is short. Short PR interval. What's the syndrome? Did you look at the internet or what? All right. So yes, Wolff Parkinson White, there is an accessory pathway. So the electrical impulse goes faster through the accessory pathway, and that's why it reflects. We call that delta wave. I don't have it here, but the electrical impulse or the polarization of the ventricle starts a little earlier, and which is called the delta wave, and that's why the PR interval is short. But you should remember, generally, if you see that the PR interval is short, you should look for these delta waves on the electrocardiogram. I can show you some other time. I don't have it here, the Wolff Parkinson White. He can find it on the internet. He is fast. All right, so normal PR interval. What is normal duration of PRS complex or the electrical depolarization of the ventricles? It should be. I don't think you need to remember the lower number. It has no physiological meaning because usually it has no pathology. But you should remember that it should be less than 0.12 seconds or 120 milliseconds. Uh, when it's wider, when the QRS complex is wider, there are many different pathologies that cause widening of the QRS complex or delaying of the delay or slow the conduction of the impulse through the ventricles or delay the polarization of the ventricles. So less than 0.12 seconds, less than three boxes, three small boxes, because we said one small box is 40 milliseconds. All right, this is so rate, rhythm, regular, irregular, sinus rhythm if there are P waves in front of each QRS complex, and then you should assess the intervals. Um, Now we'll talk about normal sinus rhythm again. I want to go through the normal rhythm before we discuss the abnormalities. Um, we talked about the electrical impulse starting in the sinus node. Um, Normal heart rate, I mentioned it briefly in the beginning, between 60 to 100 beats per minute. Uh, if the heart rate is lower, below the 60, it's called sinus bradycardia, right? Heart rate above 100 beats per minute, sinus tachycardia. Now, let's talk about basic arrhythmias. I mentioned sinus bradycardia. Due to increased vagal tone, sinus bradycardia can be normal in athletes. Athletes have very high vagal tone, and the top athletes, they can have normal heart rates in the 30s, resting heart rate in the 30s, and it still can be normal. And sinus tachycardia can be normal physiological response to different mechanisms like fever, emotional stress, or exercise. Um, what are the premature atrial contractions or PACs? So these are extra electrical activities that originate not in the sinus node, but originate somewhere in the atria. That's why it's called premature, because it starts a little bit earlier than normal sinus beat, and it originates somewhere in the atrial tissue. There is another arrhythmia which is called atrial flutter, which is also atrial rhythm, which is regular, and it is caused by the re-entry phenomenon in the atria. And then we'll talk about the atrial fibrillation. This is the most common disorganized electrical activity in the atria, causing irregular heart rhythm. We don't need to go through the re-entry. So this is the atrial fibrillation. This is the most common arrhythmia that we deal in practice every day when we are on service in the hospital. They always call us for patients who either have atrial fibrillation or develop atrial fibrillation due to different conditions. So electrical activity, disorganized electrical activity in the atrial tissue, causing irregular heart rhythm and basically chaotic impulses in the atria, uh, is called atrial fibrillation. What do you see on in the electrocardiogram in patients who have atrial fibrillation? Hmm? You don't see the P waves, right? Because there are all these small wavelets that multiple wavelets that originate in the atrial tissue. So there is no organized activity in the atria, especially not organized activity originating from the sinus node. So you don't see the P waves in front of each QRS complex. You can see little flutter waves or fibrillation waves when we talk about fibrillation. And heart rhythm is irregular because the impulse spreads through the AV node in an irregular fashion. There is no organized activity. So irregular heart rhythm and no P waves in front of each QRS complex. Um, Another arrhythmia that originates in the atria is called paroxysmal supraventricular tachycardia, which is caused by different mechanisms in the atria or the atrioventricular node. There are different types of paroxysmal supraventricular tachycardia. This is usually regular rhythm with narrow QRS, which is fast, and you don't see the typical P waves in front of each QRS complex, which you can see in sinus tachycardia. So supraventricular tachycardia is fast rhythm, regular rhythm with narrow QRS complexes, but there is no typical P wave in front of each QRS, not a sinus P wave in front of each QRS complex. And then we talked briefly about the atrial tachyarrhythmias, and then there are bradyarrhythmias causing heart block, which we will not talk about it today. Now, how is it called if you see on the electrocardiogram extra electrical activity that comes from the ventricles? That's yes, if you have three and more consecutive ventricular beats, it's called ventricular tachycardia. What about if you have the isolated ventricular beats? Premature ventricular contractions or PVCs. And I'll show you the difference between the PVCs and PACs. So PVCs, when you mentioned ventricular tachycardia, if there is a rhythm originating in the ventricles, which is regular, and then the most feared condition called ventricular fibrillation, which is a disorganized electrical activity that originates in the ventricle, usually in patients who have acute myocardial infarction. These patients basically present with acute collapse and sudden cardiac death. Unless they get defibrillation or defibrillated, they unfortunately don't survive ventricular fibrillation. Uh, so what is this? Is the PR interval, what is long? PR interval, or this is the PR interval? It's less than one big box, so PR interval is normal. The RR interval is long, right? So how many big boxes? 1, 2, 3, 4, 5, 6, 7, 8, almost 9. So what is the heart rate about? What is 300 divided by 8.5? Do you have calculator? Right, 8.5, around 35. So how is it called? There is a P wave in front of each QRS complex. PR interval is PR interval is normal. So there is no first degree atrioventricular block, but the RR interval is slow. So it's sinus beat, right? It's a sinus. It originates in the sinus and is slow. So it's sinus bradycardia with a heart rate around 35 beats per minute. It's at 30, yeah. And it's regular. Sinus bradycardia. All right. What is this? That's the opposite. Nice. So two big boxes, 300 divided by 2, around 150. It's a little bit less because it's more than so it's around 140, I think, the heart rate. You can see again the P waves, normal PR interval, P wave in front of each QRS complex. So it originates in the sinus node, and it's regular rhythm, sinus tachycardia. 130, they meant. All right. Next, PACs and PVCs. That's the basic stuff for the electrocardiogram that you should see uh, and be able to recognize on the EKG. Premature atrial and premature ventricular contractions, which are the extra beats, they don't originate in the sinus node. PACs originate somewhere in the atrial tissue. PVCs originate in the ventricular tissue. So how can you tell the difference between PAC and PVC, premature atrial and premature ventricular contraction? How much time do we have? That's one thing, yes. So because the ventricular contractions originate in the ventricle, the QRS is wide, right? There is a different morphology of the QRS complex, different axis. It can go up or down. And also, because it originates in the ventricle, there is no P wave, right? What about the premature atrial contraction? So you can see the cure. This is the PAC, which is you can see the normal size, normal morphology of the QRS complex, like in normal sinus beat. But it comes a little bit earlier. It originates uh, in the atrial tissue, so it originates or it starts earlier than the normal sinus beat, which these are the normal sinus beats. And you can also see the morphology of the P wave is different compared to the sinus P wave, right? It's like biphasic. First portion up and the second portion goes down. So it's biphasic P wave. And the P waves can be completely different. The main thing is that they are different from the original sinus P wave. So the morphology is different. It's not always this biphasic, nice biphasic P wave. So that's the PAC. Normal QRS morphology comes a little earlier, and there is a P wave which has different morphology compared to the sinus P wave. And there are two PACs here on this rhythm strip, right? There is also a little pause after the premature atrial contraction. There is a compensatory pause. Why is it? Because normally, if there is, this is the premature atrial contraction, and then there should be normal sinus beat somewhere here, right? Why it's not? Why there is a pause here? Because the atrial tissue is still in refractory. Atrial tissue is not able to be depolarized when the next electrical impulse comes too early after the PAC. So there is no atrial activity because the atrial tissue is still in the refractory period and it's not able to be depolarized. We'll talk about the refractory period tomorrow when we talk about physiology. So again, you should see and remember that there is a pause after the extra beat because of the refractory period of the atrial tissue. So these are the PACs, and this is the premature ventricular contraction. Again, different morphology, much wider, different axis, and there is no P wave in front of the QRS complex. Now, when the ventricular contractions or PVCs have different morphologies, we call them polymorphic. When they have the same morphology, polymorphic means that they are originating in different parts of the ventricles. When they are the same morphology, these are the monomorphic PVCs or premature ventricular contractions. So these are two different PVCs that are originating in different parts of the ventricles. Um, I think what time is it? 9. Uh, we'll talk briefly in the last 5 minutes about acute myocardial infarction. I started the lecture with the light presentation of myocardial infarction, but I will show you the electrocardiogram in patient who has acute myocardial infarction. Um, what do you see in patients who you suspect myocardial infarction? Patients who come to the hospital, to the emergency room, they are having chest pain. You do electrocardiogram. Uh, what are you looking for on the electrocardiogram in these patients that would lead you to the diagnosis of acute myocardial infarction? So there are two types, right? ST segment elevation or non-ST segment elevation. Um, so um, patients who have elevation of the ST segment in 2 consecutive leads more than 1 millimeter, uh, there is high suspicion for acute ST segment myocardial infarction. Patients who have non-ST segment myocardial infarction, they have ST segment depressions. And again, 1 millimeter ST segment depressions in 2 consecutive leads in patients who have typical presentation suggest that they may have acute non-ST elevation myocardial infarction. It's 9 o'clock. I have more and more slides about the electrocardiogram, but I don't think we will be able to go through these. I just want to show you. I think you're going to talk about it in the small group session about the vectors and the EKG. Right, Mark? Um, Here. This is the EKG, the electrocardiogram of typical patient who comes with ST segment microinfarction. You can see that there is an elevation. This is the isoelectric line where the normal PR segment and the ST segment should be, and you see that ST segment is elevated. It's about 5 millimeters uh, in several leads, V2, V3, V4, and V5. So this is these leads overlie the left ventricle. So this is acute anterior wall myocardial infarction, usually caused by the occlusion or severe stenosis of the left anterior descending artery. So remember, acute infarct, ST segment elevation or ST segment depression more than 1 millimeter in 2 consecutive leads. There are other criteria that we assess, but this is the most common. I think I'm gonna stop here because we don't have enough time for the rest of the slides. So this was just the basic EKGs. We can talk about it in a small group session about the rest and how we assess. Um, I hope you learned something from the basic. It is more and more complicated when you evaluate EKGs and pathology, but you really have to start with the structure. And when you read every electrocardiogram the same way, then there is a less likely that you miss any pathology. Any questions? Thank you.